Hello everyone, welcome to JRM Paediatrics. In this video, we shall be learning about EEG, that is electroencephalogram. Just a few pointers and how to identify a few major ones. Now, what is EEG? EEG is electropotential difference between two electrodes. Now, on skull there are four landmarks on basis of which the EEG leads are placed. They are nasion, anion on the occiput, right and left preauricular points just in front of the tragus. Now these leads have a code, that is right side and left side. On right side it is red in color, represented by even number. On left side they are blue in color, represented by odd number. We can remember one and the other one will be opposite of it. Now in red we have R for right, E for even. So for left it's the opposite one, that is blue and odd. Now these leads have some abbreviations attached to them. FP stands for prefrontal, F for frontal, C for central, T for temporal. Now middle and posterior temporal are represented by T34 and T56 respectively. O for occipital, P for parietal. For F, C and P associated with Z written to it, it stands for front vertex, central vertex and parietal vertex. Now of all these leads, whatever their abbreviation is, they represent that area, like F for frontal. However, there is only one exception. F7 and 8, they record the anterior temporal activity, but since they are placed on the frontal bone, they are labeled as F7 and 8. Now in neonates, since the skull area is less, 11 electrodes are placed. Here we read about 21 electrodes. 11 electrodes are placed where the frontal and parietal are usually omitted. Now coming to the placement of electrodes, there is a system known as 10-20 international system. Now what does it mean? That between the electrodes and the skull landmarks, there has to be a distance of 10% or 20%. As you can see here, from nasion to this electrode, it is a distance of 10%. Then subsequently 20%. Again from inion, there is a distance of 10%. Then subsequently 20%. Similarly, it is mentioned here. So we need to learn the name of this, that is 10-20 international system of placement. Now let's have a look at normal waveforms. Now for normal waveforms, first we have to remember what are they. Delta, theta, alpha and beta in increasing order of frequency. So there is a mnemonic known as D-tab, delta, theta, alpha and beta. Delta is for 0 to 4 Hz, theta is for 4 to 8 Hz, alpha is for 8 to 13 Hz, beta is for more than 13 Hz, can go up to 30 Hz. Now delta is seen in deep sleep, theta in sleeping, alpha is seen when the patient is awake and resting, beta is seen when a person is awake with mental activity. This has to be mental activity here. Okay. Now let's have a look at the normal waveforms here. As you can see here, I have marked the 1 second in a line for you to count the hertz. It would be easier for us. Now in case of deep sleep, as we can see, 1 second. Now in case of deep sleep, as we can see, it stands for 0 to 4 Hz delta waves. Okay. So there is 1 and 2. So 2 Hz delta waves. Now in sleeping we see theta waves. That stands for 4 to 8 Hz. So 1, 2, 3, 4, 5, 6, 7. Now in case of awake and resting, we have alpha waves. That is for 8 to 13 Hz. So we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. Okay. This is alpha waves. Now In case of beta waves, we have awake with mental activity. So you can see there are a lot of waves here. The frequency has increased. Beta is for 14 to 30 Hertz. Okay. Now let's move on to what is background rhythm. Background rhythm is basically when an EEG is done, even in case of seizure disorder patients, there is a background rhythm, posterior dominant rhythm that goes on. In case of awake person, it varies as per age. That is, in case of infants, it is 4 to 5 Hertz. In a child, 5 to 8 Hertz. And in adult, 8 to 10 Hertz. Basically, as a infant or from the neonate phase, as a child grows, it begins with delta activity and then it gradually increases to increase in frequency. Now in case of sleep, it can be light or deep sleep. For light sleep, it is 5 to 6 Hertz, and for deep sleep, it is a delta activity that is 3 to 4 Hertz. Now let's have a look at the abnormal waveforms. First is a spike wave. As you can see, there is a spike here. It is less than 70 millisecond duration. Then the sharp wave. Now this also is a sharp spike kind of thing. But what's the difference between the spike and sharp wave is the duration. Sharp wave is 70 to 200 millisecond. Next is a slow wave, which is more than 200 millisecond. Now these can be combined as well, like the spike and wave pattern. There is a polyspike pattern and polyspike and wave pattern. Okay. These are a few abnormal waveforms that we can usually see in EEGs that we do. Now coming to spike and slow waves. Now the spike and slow waves can be focal or generalized. If there are focal spikes, then it is suggestive of an irritative lesion like a cyst, slow growing tumor or a glial scar tissue. If it is a focal slow wave, then it is suggestive of less irritative circumscribed lesions like hematoma, tumor, infarction or abscess. Now in case of generalized, if it is generalized spikes, then it is suggestive of GTCS type, and generalized slow waves is suggestive of encephalitis or encephalopathy, that is coma-like situation. Next, let us come to a very important thing, something known as the periodic complexes. Now what is periodic complex? Periodic complex is basically a burst of waves at regular intervals. Now it can be polyspikes or slow waves. Polyspikes come like this. See, in burst of intervals there are polyspikes. Now polyspikes are seen in myoclonic epilepsy. In case of slow waves, again there is generalized and focal. Generalized slow waves of periodic complexes are seen in SSPE first and Creutzfeldt-Jakob. However, focal periodic complexes, very importantly, seen in HSV encephalitis. Here it is known as PLED, that stands for periodic lateralized epileptiform discharges. Okay. Now coming to a few patterns that we see. They are 3 Hertz spike and wave per second is seen in absent seizure. Hips arrhythmia is seen in infantile spasm. 4 to 6 Hertz polyspike wave pattern is seen in JML. 1 to 2 Hertz spike and wave per second is seen in Lennox-Gastaut. Now low voltage EEG pattern is seen in case of suppressed brain, like for encephalopathy, encephalitis, if it is a generalized low voltage. However, if there is associated to a focal site, then it can be due to localized slow waves to a focal lesion. Then centrotemporal polyspikes are seen in Rolandic epilepsy or BECTS, that stands for benign epilepsy of childhood with centrotemporal spikes. Then in coma we see a generalized symmetrical depressed brain activity. Flat EEG is suggestive of brain dead, flat ECG cardiac death, flat EEG brain dead. Now very importantly, a burst suppression pattern. There are few case scenarios where we see a burst suppression pattern. They are Otahara, coma, hypothermia and general anesthesia. Now this is it for the theory part of EEG. In the next video, we'll be learning with a few practical examples, that is a case scenarios based approach to learn about different patterns of EEG. Thank you.